Welcome, everyone. Thank you for joining me today as we think together about how we optimize the use of ovarian function suppression for our patients with early stage breast cancer. So, I want to share some cases from my own practice. So, this first patient is a 32-year-old Black woman. She presented with a mass about 10 months after the delivery of her third child. She had felt this a couple of months earlier, as often happens, thought that this was a blocked duct from breastfeeding. But when it persisted after weaning her child, she came for evaluation. Now, on exam, she had a 4 centimeter mass with palpable axillary lymph nodes. Imaging was concerning, and a biopsy found a poorly differentiated but ER and PR positive HER2 negative tumor. An MRI found an additional area in the same breast, and biopsy of that additional area found only DCIS. She had systemic imaging that found no distant disease, and genetic testing found a pathogenic BRCA2 mutation. Now, she at that point said she had no plans for future pregnancies, so she was not referred to a reproductive endocrinologist. And based on that, we had not planned ovarian function to preserve potential fertility as part of her chemotherapy. She started neoadjuvant chemotherapy with a sequential anthracycline and taxane regimen and had an excellent clinical response. And based on her genetic mutation, she elected bilateral mastectomy that found a residual 8 millimeter area of disease in the breast, but all negative lymph nodes. At the time, there were long conversations about post mastectomy radiation. She enrolled on a clinical trial for patients who had sentinel or had lymph nodes positive at diagnosis, but sentinel lymph nodes negative at surgery, and was randomized to no radiation. Her menses had become irregular during chemo, but never completely resolved. And as she was finishing her active treatment, she began to revisit whether future fertility was important for her. So, in her case, as we began to talk about hormone therapy, we considered several options, ranging from tamoxifen, ovarian function suppression or oophorectomy alone, adding tamoxifen to ovarian function suppression, or ovarian function suppression with an aromatase inhibitor.
Before you continue, one of the things that we put in the survey, I never thought about it until I talked to Anne before, was the issue of do you offer ovarian suppression during chemotherapy to young women who maybe are not interested in fertility but would like to avoid premature menopause? Is that a thought you ever have?
So I have, particularly in our patients with ER negative disease, where I would not be thinking about ovarian function suppression as part of their treatment. I have not done that other than to preserve fertility for patients whose tumors are ER positive, because in those patients, I'm often thinking about whether ovarian function suppression is going to be part of their therapy rather than as a protective.
Although, really, even if it is going to be part of their therapy, it's really a question of timing, whether you want to start before the chemo or not. Do you have concerns about doing that? The old thing about, hormones and chemo together?
So I think we don't have great data on that, Neil. We do know that doing concurrent tamoxifen with chemotherapy reduces the benefits of chemotherapy, but we don't have similar data for ovarian function suppression for our premenopausal women. And we know that chemotherapy rather can be effective in postmenopausal women. But I do think it's an interesting question. I tend to favor trying to preserve fertility for our young patients who identify that that's important to them. But I don't have a way of parsing the data to know if ovarian function suppression in those patients started before chemo for that purpose might reduce the benefits of chemo.
But that's really interesting. I never heard that before, that tamoxifen does interfere with chemo and ovarian suppression doesn't. That's cool.
Well, we don't know if ovarian suppression does.
Ah, okay.
We know from a previous intergroup trial that tamoxifen does, but that has not been
Right,
studied with ovarian function suppression.
right. Okay, please continue.
So, hormone therapy is not a new idea. This was actually first identified serendipitously all the way back in 1882 when a surgeon reported a perimenopausal woman whose breast cancer regressed as she went through menopause naturally. And that led Scherzinger to propose oophorectomy as adjuvant therapy. But the first person to act on that intentionally was the British surgeon Beatson, who removed the ovaries of a premenopausal woman with cutaneous metastasis and saw that those cutaneous metastases regressed. The first adjuvant use was just a year later, and we don't have reports from Boyd on whether that patient who had her ovaries removed in the adjuvant setting ever had disease recurrence. Now, unfortunately, the first large trial to test this was the ECOG 5188 trial. That trial enrolled just over 1,500 premenopausal women with lymph node positive, ER positive disease. Now, I have to take you back to our understanding of breast cancer and hormone therapy and chemotherapy in the late 1980s. At that point, many people assumed, some thought they knew, that tamoxifen would not be effective in premenopausal women. So this trial was really designed to test whether tamoxifen would be effective. So it randomized patients to CAF chemotherapy, the same chemotherapy with the addition of ovarian function suppression, or chemotherapy, ovarian function suppression, and tamoxifen. Now, the results are shown for you here. In aggregate, there was a significant reduction in the risk of recurrence by adding tamoxifen. They were not able to see a difference by adding the ovarian function suppression. When they honed in on age, there was a suggestion in the youngest patients that perhaps ovarian function suppression had something to offer. Now, there are some problems with this trial. We've talked a little bit about the questions about tamoxifen, but they underestimated the impact of chemotherapy on ovarian function. And they didn't ask women if they continued to have menses during their chemotherapy or after chemo. And they didn't assess hormone therapy. So that subset analysis that we looked at, looking at patients under age 40, was really a surrogate for the patients most likely to still be premenopausal after chemotherapy, but it was less than 500 patients and very much underpowered and unplanned. So those results, as suggestive as they were, really never impacted practice. Now, we do learn from our failures in the past. And now, 12 years ago, we launched both the SOFT and TEX trials. SOFT randomized premenopausal women with ER positive disease to tamoxifen, ovarian function suppression with tamoxifen, or ovarian function suppression with an aromatase inhibitor. We've just recently seen 12-year follow-up data still showing significant reductions in distant progression-free survival or recurrence-free survival, but now also seeing a significant improvement in overall survival. Now, the TEXT trial randomized patients who were receiving ovarian function suppression to exemestane or tamoxifen. So they were able to combine the ovarian function suppression arms of SOFT with TEXT to give us about 4,600 patients, so a larger analysis with more power. Those 12-year data also confirm significant improvements in disease-free survival, distant recurrence-free survival, and overall survival. Importantly, the significant improvement in overall survival was independently seen in several high-risk groups. Those patients less than age 35 had an absolute 4% improvement in overall survival. Those with tumors greater than 2 centimeters, a 4.5% absolute improvement in overall survival. And grade 3 tumors, regardless of the size and nodal status, a 5.5% improvement in overall survival. So, when I talked to patient one about her options for hormone therapy, our initial plan was ovarian function suppression with a monthly LHRH agonist. We would then add an aromatase inhibitor after her ovarian function had been suppressed. Now, this is a young premenopausal woman, and we need to think carefully about the formulation. And there have been several studies suggesting that depot formulations may not maintain consistent ovarian function suppression throughout the 3 months. So I would strongly urge you to use the monthly formulations. Now, our second patient is a 32-year-old woman who presented with inflammatory disease. Her tumor was strongly ER and PR positive and HER2 negative. This is a woman who was morbidly obese with a BMI of 36. She told me she had had irregular menses throughout her adult life, and based on her body habitus and her history, I wondered if she had polycystic ovarian syndrome, but that had never been formally diagnosed. She was adopted and her family history was unknown, and an expanded panel genetic testing did not find any pathogenic mutation. After confirming that she did not have any metastatic disease, we began to talk about options for therapy. She identifies as a lesbian who was not at all interested in childbearing or fertility preservation. She began neoadjuvant therapy with a sequential anthracycline and taxane-based regimen, clinically had a complete response. She elected bilateral mastectomy because of her desire for symmetry and concern about musculoskeletal compromise given a potentially large discrepancy in breast size, and that found a pathologic complete response. She did undergo post-mastectomy radiation and then received olaparib with radiation on the SWOG IBC trial. Now, her menstrual history is a bit challenging because she had irregular menses ranging from every 3 to 6 months, even before chemotherapy. She had one light cycle between cycles 2 and 3, but had not had any menstrual bleeding since that time. So, as we began to think about her hormone therapy, our first question was really, is she menopausal? Now, the definition of menopause is not going to apply to her because the definition of menopause is 12 months without spontaneous menses in the absence of interventions like chemotherapy or medications that may impact ovarian function. Now, we do have some predictors of chemotherapy related amenorrhea. In general terms, the closer you are to natural menopause when you get chemotherapy, the more likely you will become menopausal with chemo, and the more likely that will be permanent. The challenge is there is a really wide range of how old women are when they go into natural menopause. There's been some studies suggesting that lower pretreatment levels of the AMH, the anti-Müllerian hormone, which is often used in reproductive circles to predict ovarian reserve, might also predict a greater risk of chemotherapy-induced amenorrhea. We could certainly check her hormone levels. The challenge being ovarian function can vary over time. So, checking those hormone levels will tell you if the ovaries are functioning at the time you checked them. It really is not going to tell you if the ovaries will be functioning a week or a month or 3 months later. It's also important to remember that checking those hormone levels while a woman is on tamoxifen can make interpreting those values very challenging. Now, we also know that decreased peripheral conversion of testosterone and other adrenal steroids to estrogen driven by aromatase inhibitors can stimulate the menses to resume. So this is just the simple feedback loop of basic physiology. If you decrease the peripheral conversion, estrogen levels decrease. That increases FSH and LH production in the pituitary. And if the ovaries have the ability to still respond, you may actually stimulate estradiol production, in some cases enough to resume menses, and in a couple of very famous cases, enough to trigger pregnancy. And when this has been studied in some small studies, up to a quarter of women who are amenorrheic have premenopausal estradiol levels. So, in this case, as we considered these options, both the patient and I were uncomfortable with an aromatase inhibitor alone, and we felt that would require ongoing monitoring of hormone levels to make certain that she remained appropriately suppressed. We also had concerns with tamoxifen. She is a very young woman who had very high risk disease, and tamoxifen would be at least somewhat less effective. It would also bring with it a higher risk of thromboembolic disease, and based on her body habitus, that was, I thought, an even greater risk for her. She had concerns about the out-of-pocket cost for ongoing LHRH agonist therapy, as well as the frequent clinic visits to receive the injections and for monitoring. So for all of those reasons, together we thought that a bilateral subpingual oophorectomy was a better option for her, and then she could safely begin aromatase inhibitor therapy.
Okay, just a couple of questions. So the olaparib, that's a radiation potentiator, and is it just inflammatory or beyond that?
So that trial is specifically for women with inflammatory disease, irrespective of disease phenotype or response to neoadjuvant therapy, and it does not require genetic mutations. It's really based on when PARP inhibitors were first contemplated all the way back by Sir Hilary Calvert. It was with the thought that they would potentiate the response to DNA damaging therapies, one of which would be radiation. And since patients with inflammatory disease have at least a 20 to 25% risk of recurrence in the chest wall, which is why we recommend radiation even for those women who have a pathologic complete response. The goal of this trial is to improve the effectiveness of radiation in this high-risk population.
Are you aware of a lot of other trials inside or outside of breast cancer looking at olaparib as a radiation potentiator? I never
So,
heard that.
there have been a couple of pilot trials to show the safety in breast cancer. We have one local trial actually for patients who do not have a complete response, who still have gross residual disease, that looks at adding a different PARP inhibitor with radiation in the preoperative setting. And there's been one trial proposed, and I think it may still be ongoing, looking at PARP inhibitor as a way of potentiating the benefits of radiation for patients with CNS disease.
Interesting. And this is one arm or randomized?
So it's randomized to the olaparib or not.
Good. Great. And then the other thing I was going to ask you about your first case is I'm not sure exactly of the timing, but she was BRCA2. Was she considered for adjuvant olaparib or was that before that?
It was before then.
If it had been now, I'm just kind of curious, and I was going to ask both you and Ann in general how you deal with that situation. What do you think you might be thinking about olaparib?
So we'd have to make a bit of an extrapolation. So in the adjuvant trial, eligibility was different for patients whose tumors were ER positive compared to triple negative. The triple negative patients were eligible if they had residual disease after neoadjuvant chemotherapy, even if it was just a millimeter of residual disease. The ER positive patients had to have involvement of 4 lymph nodes at the time of definitive surgery, even if they had received neoadjuvant chemotherapy before that surgery. So she would not have been in that very high risk group to be eligible for the trial. Now, I suspect proportionally the benefits would be the same, but as her risk would be lower, the absolute benefit would be lower. So I think it's something she and I would have talked about, but we don't have data that would directly apply to her situation. Why there were not a whole lot of ER positive patients in that trial, and it made the eligibility for that trial really challenging, because the majority of our triple negative patients would have gotten neoadjuvant therapy. If you assume a 50% pathologic complete response rate, then a lot of patients are no longer eligible. And the folks with ER positive disease had to have really bulky gross disease. And many of those women would have also had neoadjuvant chemotherapy. While their response is less, their likelihood of path CR is less. To require 4 positive lymph nodes really requires pretty bulky disease even after chemotherapy, or for those patients who have gone directly to surgery and then gotten chemotherapy in the adjuvant setting.
I mean, if you think about that case with just a little bit of residual disease, but still there was a little disease, even with ovarian suppression and all the other things that you're doing, what do you think the residual relapse rate would be?
So for her, it's probably not nearly that high. And I think we don't have perfect data here, Neil. The difference in outcome based on residual disease in compared to no residual disease in our patients with ER positive disease is not that great. It's not that great a predictor of their long-term outcome. Now, we assume that's because for many of those patients, the most important systemic therapy is their hormone therapy, which they've not yet gotten in the neoadjuvant setting. So that really attenuates the difference based on response to chemotherapy. Now, as we get better at using molecular subtyping to distinguish amongst the larger group of patients with ER-positive disease, we may be able to find a subset of patients with ER-positive disease for whom path-CR and residual disease has a similar effect, but I don't think we've fully been able to hone in on that group just yet.
Really interesting. Please continue.
So our third case is a 28-year-old woman whose breast cancer, interesting enough, was found as part of an infertility evaluation. Her reproductive endocrinologist did a complete history and physical, including a breast exam, and identified a 1 centimeter breast mass on exam. On imaging, this was a 2.8 centimeter area. Lymph nodes appeared normal. Biopsy found a poorly differentiated tumor that was ER/MPR positive and also HER2 positive. She had expanded panel genetics that did not find a pathogenic mutation, did find a variant of unknown significance. She, as you might imagine, was very interested in preserving her fertility. Working with her reproductive endocrinologist, she had 1 cycle of oocyte retrieval pre-chemotherapy that yielded 6 good quality eggs that were fertilized and then tucked away in storage as she proceeded to neoadjuvant THP. She began an LHRH agonist a week before her first chemotherapy in hopes of maximizing the potential to preserve her future fertility. She ultimately then underwent breast-conserving surgery with a sentinel node biopsy that confirmed a pathologic complete response. She completed radiation and a year of HER2-targeted therapy, and she continued the LHRH agonist as part of her hormone therapy initially. She really struggled with the toxicity of hormone therapy as we added the aromatase inhibitor. So we actually backed off her hormone therapy to continuing the LHRH agonist, but in conjunction with tamoxifen, and she tolerated that fairly well. 3 years later, quite frankly, she was both tired of the menopausal side effects, and she and her husband were very interested in moving forward with attempts at pregnancy. And she had very good questions. First, is this possible? Is it safe? If I stop the ovarian function suppression, when my menses resume, when could we proceed with attempts at conception? And what's the impact of attenuating at least that component of my hormone therapy for less than 5 years?
So, as you think about this case, one thing before you get started in terms of going through it, which I'm not, again, I wonder if it's been clarified, is do you think through her hormonal strategy differently because she's HER2 plus in any way?
No, actually, I don't. I think what we have seen as the data have accumulated is that our patients with ER positive, HER2 positive disease behave a bit differently than those with ER negative, HER2 positive disease. They certainly still benefit and should be treated with HER2 targeted therapy. But we do see late recurrences in those patients who are HER2 positive, ER positive. In the same way, we worry about recurrences after 5 years in those patients whose tumors are ER positive and HER2 negative, and they do still benefit from hormone therapy.
Well, that's usually what people talk about when you talk about ER positive, ER in the setting of HER2. But I'm kind of thinking more about the hormones, not about the anti-HER. So your hormonal strategy, your fertility strategy, everything into the timing of therapy, when you use, LHRH agonists during chemo, all that is exactly the same, whether they're HER2 positive or not, in your mind.
In my mind, yes.
Do you think that's true in most people's mind as people practice? And
Um,
also, it also gets, I don't know we're talking about adjuvant now, but also as it relates to metastatic. To me, I feel like people are not necessarily approaching it exactly the same way. I'm not sure why, though.
well, I think there are a couple of reasons why they're not, and I think you're right. There are, I'm sure, people who would say the HER2 status impacts how they would approach the hormonal therapy. First, the data we have looking at ovarian function suppression come from trials before HER2 was routinely tested in many places, and before HER2 patients were preferentially segregated to trials focused on HER2. Now, that doesn't mean that they didn't enroll patients with HER2 positive disease, but by and large, we either don't know who they are or they were identified based on retrospective testing and retrospective subsets. And it's difficult to make a lot of that data because most of them did not get treated with HER2 targeted therapy. So it's fair to say we don't have a lot of data that we can employ without a bit of extrapolation. That said, ER is still functional in those women. They still benefit from hormone therapy. They're still at risk of long-term later recurrences. So I look at this as you have two pathways that are active in your tumor. They are both important and you benefit from inhibition of both. And we ought to optimize inhibition of both to maximally improve your outcome.
Okay, please continue.
So we do have some data to help us answer this patient's questions. So from the IBCSG-8 trial, which randomized patients to either gaserelin as a method of ovarian function suppression, CMF, or CMF then followed by gaserelin, and it gave the gaserelin in both of those two arms for 18 months. We do have information on the number of women who resumed menses and the time course. Now, age did have a factor here, and the vast majority of patients less than age 40 had resumption of their menses on average within 6 months of their last dose of gaserelin, and only about 10 to 15% of patients did not have resumption of their menses. For our premenopausal but older patients, more of those patients did not have resumption of their menses. It took a little bit longer, but about 50% of patients had resumption of their menses within a year of stopping gaserelin. Now, that trajectory was very different for patients who received chemotherapy. For those patients who received chemotherapy, many more women became permanently amenorrheic, and there was still some age distinction. We also have data more recently from the ASTRA trial looking at ovarian suppression with tamoxifen compared to tamoxifen alone. Only in breast cancer would you say slightly smaller trial of about 1,300 patients, but in that trial, the ovarian function suppression was given for only 2 years. And we've now seen 8-year follow-up results still showing about a 5% improvement in disease-free survival, not yet a significant improvement in overall survival, though the number of events are quite small. And for an ER positive cohort, 8 years for overall survival is actually fairly short. We also have data about pregnancy from the positive trial, which I think is one of the more important trials that we've done over the last several years. The positive trial was designed with exactly this woman in mind. Premenopausal women, ER positive tumors, on hormone therapy for some period of time, interested in interrupting hormone therapy for attempts at pregnancy. So the positive trial was not randomized, but it enrolled just over 500 patients in that group and with those desires. They had been on adjuvant hormone therapy of some sort for 18 to 30 months. At the time of enrollment, they stopped their hormone therapy and then were off hormone therapy for up to 2 years for attempts at conception and delivery, with the plan that they would then resume hormone therapy to complete either 5 or 10 years total duration. Now, here are the outcomes thus far. Just under 500 patients, 3/4 of them have had at least one pregnancy, 2/3 have had at least one live birth. Rates of pregnancy and delivery complications very similar to what you might expect from age population matched group of women. Almost 2/3 of the women who wanted to breastfeed were able to breastfeed. When we looked at their disease outcomes, while we don't have randomized comparisons, they were able to use data from the soft and text as a contemporaneous comparison. And there did not appear to be a significant increase in the risk of either new breast cancers or distant recurrence. So, this gives us a lot of information to be able to talk to this woman, tell her what she might expect, and that at least with this experience, we don't see a risk of increased recurrence or new cancers that should tell us absolutely not. She needs to remain on hormone therapy for the full duration, uninterrupted, and that to do anything less is dangerous for her or for her family. I think it also means we need to develop a closer relationship with our reproductive endocrinologists, as our goal for these patients who are interested in interrupting hormone therapy still is to try to minimize the period of time that they're off hormone therapy until they've completed delivery and are resuming treatment. So I suggest that my patients interested in this meet with a reproductive endocrinologist before we interrupt their hormone therapy, that we have plans for them to begin intervening in assisted methods that are consistent with the patient's goals, and assisted methods that she and her family would accept sooner than might otherwise be the practice of the reproductive endocrinologist for a woman of that age, with the goal of maximizing her chances that she's able to become pregnant and minimizing the period of time off therapy. So this was the POEMS trial from many years ago, that looked at women whose tumors were ER and PR negative. So ovarian function suppression hormone therapy was not a therapeutic consideration, but these were women with hormone negative tumors, premenopausal, needing chemotherapy, interested in preserving fertility. And they were randomized to chemotherapy alone or chemotherapy with gaserelin, and the trial specified gaserelin as an ovarian function protector. It started the gaserelin 7 to 14 days before initiating chemotherapy, then continued it during chemotherapy, stopped the ovarian function suppression once chemotherapy was done. Its primary endpoint was actually number of pregnancies, a number of successful childbirths, and it did improve the likelihood of becoming pregnant and delivering a live baby in that population. Also significant reduction in the number of women who were permanently amenorrheic and dealing with menopausal symptoms. So the NCCN guidelines follow that trial, which used gaserelin.
That's interesting. I'm not sure whether people have a preference for one, gaserelin versus leuprolide. Do you have a preference?
I have no preference at all. We've recently had some drug supply issues that have required me to change patients from one to another, and I've had patients whose insurance provider has preferences. I think they work identically. I'm equally comfortable with any of them.
And you said what is one of them is in short supply? Which one?
So Leuprolide recently had some supply chain issues that I
Huh.
think have been resolved, but there was a period of several months where I had to switch some patients to gaserelin because we were not able to get Leuprolide.
Just a couple of follow-ups. One, I forgot to ask you about the current state of the three patients you presented, what their current status is.
So the first one became non-compliant with her LHRH agonist therapy in the adjuvant setting when she came back to reinitiate therapy. She had not had menses for 2 months, and we discovered she was pregnant. So
Wow.
yes. So she delivered a healthy baby, is now very clear that she is done having babies. She is back on an LHRH agonist for which she has been compliant. She is in that state that I see with a lot of my patients where it says she does not want more babies, but oophorectomy, which would make that permanent, it is a bit of a struggle for her. So she is still on her LHRH agonist, and we continue to chat about at what point she would be amenable to moving forward with surgery because she has a BRCA2 mutation. So we have other reasons to think about surgery for her.
Right.
The second patient continues to do extremely well. She continues on her aromatase inhibitor. Her inflammatory disease was now about 3 years ago. She has not had recurrence. She's been working on her physical and mental health and doing quite well. The third patient actually was on the positive trial. And she is one of the women in the positive trial who had a baby. And she
Wow.
and baby have done quite well. And she's actually back on her hormone therapy after delivery.
Wow. It's hard to believe it was only presented in December because we've talked about that study so many times already almost on so many of our programs. Another thing I was going to ask you, the woman who was on the olaparib radiation trial, I think that was the second one.
Mhm.
Did she have what dose of olaparib did they use, and did she have any tolerability issues, cytopenias, GI?
So they're only on the olaparib for about 6 to 7 weeks. The olaparib is only during the period of radiation. So she did not have significant cytopenias, which I think, given that limited duration of therapy, is not particularly surprising. She did not have issues with nausea. She had a pretty brisk skin reaction in the acute setting, but she also is a very large woman who needed comprehensive nodal radiation with her inflammatory disease. So I certainly couldn't say that her skin reaction was more than you might have expected for her BMI and the radiation that she needed.
That's an interesting point. I didn't think about. You ought to. I guess obviously you're going to look at toxicity of radiation therapy because maybe
Mm-hmm.
that's going to be worse. Another thing I actually asked Ann about this a long time ago. We're getting ready to go out to the GU symposium next week, and of course we're doing a big symposium on prostate cancer. And they're all talking about the oral agent relugolix, the antagonist, and
Mm-hmm.
yet it looks like it has not been looked at in breast cancer. And I'm like, why?
So, to my knowledge, it has not been evaluated in breast cancer. Physiologically, it would certainly make sense. We, of course, would want to test that, but I don't think that's been done. There certainly may be studies ongoing that I'm not aware of.
I mean, I would assume it would have the same quality of life advantage as it does to prostate cancer patients, not having to come in.
Yeah, that's the biggest, that I think would be the biggest difference, because otherwise the toxicities all come from blocking ovarian function and lowering estrogen levels. And if it's having that same physiologic effect, those toxicities, I think, would be the same.
Yeah, the only thing I've heard people say is, maybe compliance is going to be even more important in women, particularly if they're on an AI and, that whole thing. So I'm really looking forward. Go ahead.
It is an interesting question, Neil. Compliance and adherence with oral versus IV therapy, I think, is a bit of a tug of war. Monthly visits to the clinic, even though they can be fairly quick, certainly can get tiresome. They can be challenging if you're from farther away and you have all of those logistic issues. But at least from the physician point, I know what you got because I know if you came and you got your shot or not. Adherence with oral therapy gets trickier. And we do know from some sophisticated studies that adherence with oral hormone therapy, particularly over chronic therapy, is not particularly good. And I suspect this agent would not necessarily be different.